Hello everyone, I'm Zhiyi Sun. I will be presenting our work on using large language models for authoring precision feedback messages by iterative prompt engineering. Healthcare professionals need continuous learning as knowledge evolves. Traditional clinical feedback helps, but often lacks engagement. To improve this, we develop a precision feedback system that adds coaching and appreciation messages. To be more specific, our precision feedback prioritizes coaching and appreciation messages. It uses estimate of the motivational potential of feedback to drive performance improvement and sustainment. To illustrate, here are some examples of precision feedback. The first is an appreciation messages with social comparison, which acknowledges Dr. Jen's achievement and high performance. The second example offers a coaching feedback which identifies an area for improvement. This is a detailed appreciation messages with social comparison. It offers specific performance metrics and directs Dr. Jin to a detailed report, encouraging engagement with her performance data. Now, let's explore the evaluation feedback mechanism. It typically includes standard audits with feedback, displaying current performance levels, comparing performance, and showing performance changes over time. Coaching feedback targets growth by identifying learning opportunities and encouraging improvement. Appreciation recognizes achievement and motivates sustainable performance. The five different types of performance among appreciation and coaching feedback. There is high performance achievement, low performance and improvement, and low performance and loss. For each of performance, there are three types of feedback messages regarding comparisons. Comparisons to goals and standards, such as your performance is above the goal. Social comparison, such as you reached the top performance benchmark. And also comparator not specified, such as congratulations on your consistently high performance. In this study, our goal was to explore how LLMs could effectively generate motivational messages. Developing knowledge bases manually is complex and time-consuming. We wanted to see if generative AI could streamline this process, but its effectiveness for creating messages and metadata remains unclear. So, there are two key questions. First, can LLMs compose acceptable motivational messages? And can LLMs generate appropriate metadata for precision feedback messages? We use Mistral Large 2 and ChatGPT 4o to generate 25 coaching and 25 appreciation messages. Over three iterations, we refine prompt and evaluate the messages qualitatively for correctness, consistency, and acceptability. In the first iteration, we started with a basic prompt and minimum instructions, conducting informed analysis of acceptability. In the second, we added key terms, definitions, and metadata about message types and cutoff pathways to improve precision. By the third iteration, we incorporated detailed workflow instructions and structure examples, which further improved clarity. You can pause here if you'd like to see this detailed result in the table. From our iterations, ChatGPT showed a 36% success rate, generating 18 coaching messages but no successful appreciation ones, while Mistral had only a 16% success rate with 7 coaching and 1 appreciation messaging. We faced challenges like metadata inconsistencies and duplicate, noting that ChatGPT produced a broader range of messages, but some fell outside the system scope. Building on our result, we found that refining prompts lead to better LLM performance. ChatGPT produced a wider range of performance, though some were irrelevant, while Mistral generated more duplicate that closely mirror examples. The key insight is that while LLM can create some useful messages, further refinement is essential. In conclusion, our findings suggest that LLMs have potential for authoring precision feedback messages, but require improved prompt refinement and a more advanced evaluation method. Moving forward, we plan to integrate the retrieval augmented generation, develop stronger frameworks for accessing message quality, and share refined prompt as knowledge artifact to enhance future research. You're welcome to scan the QR code to explore our precision feedback knowledge base and learn more about our work at Display Lab. Thank you.
Hi everyone. Thank you for being here today. My name is Prajwol. I'm a graduate from the University of North Florida. I'm excited to present our research on towards counteracting nutrition misinformation in social media using the US dietary guidelines. We're living in a time where social media has an enormous influence. Platforms like Facebook, Twitter, Instagram having billions of users are both significant source of information as well as breeding ground for misinformation. Particularly, we see a rise in misleading claims about nutrition that can affect public health decisions. This work seeks to address this growing concern by identifying and mitigating nutrition misinformation on Instagram. To give you some context, social media has become a major source for misinformation, especially during the COVID-19 pandemic. According to a research, 50.5% of the 1,225 fake news originated from these platforms. Thus, our goal is to build tools to detect and warn users about such misinformation using the US dietary guidelines as a baseline for the truth. According to a study, seed oil usage and low carb or no carb diets are two of the popular sources of misinformation in nutrition. So this research focuses on these two prevalent topics of misinformation in nutrition. The primary objectives of our work is to detect and warn users about misinformation related to nutrition topics on social media and further guide users towards evidence-based nutrition information, especially using the US dietary guidelines. For the data collection, as already mentioned, we focused on the seed oils and the carb diets from Instagram. In total, we collected 33 samples on the seed oil uses and 31 samples on the carb diets. Let's see an example to understand this process of data collection. So this is a real Instagram post that has multiple images and caption and a caption. And an Instagram post has a single caption, as can be seen on the covered by the red box, but can have multiple images and videos. This post has two images in it. The red box is the caption of the Instagram post, and the blue and the green boxes are the first and the second images. As you can see, this table here, the red field text represents the caption that is scraped from the Instagram post. The blue field represents the first image that is transcribed into text, and so on for the green field. The labels, whether these posts after appending these texts are misinformation or not, is determined using the reference from the US dietary guidelines by the help of our field experts. Now, after preparing this data, it's ready for training the machine learning models. The data set at first is split into train set and the test set. The training set is used to fine-tune the BERT large language models, especially BOT-based, Robota-based, and BioBERT. And the testing set is used to evaluate the fine-tuned models and further measure the performance of these different models. Upon inference, we obtained, these results as can be seen on table 1 and 2, where we trained and evaluated the seed oils data and carb diets data separately. The Robota model outperformed the other models, BioBot and BOT-based, across both datasets, showing the most balanced and effective performance. In both datasets, certain credible posts were classified, misclassified as misinformation due to language factors like sarcasm or controversial statements or over exaggeration of contents, which is actually a popular way to put posts on Instagram as well. So in the future, we aim to improve data extraction and classifier performance by incorporating video transcription techniques and developing a more robust pipeline with larger datasets to automatically identify relevant posts. We also want to develop tools to detect misinformation across various nutrition topics while providing warnings to the users based on the US dietary guidelines. In summary, this research is a first step towards a larger goal, ensuring that the social media users are equipped with accurate and reliable nutrition information. By leveraging machine learning and the US dietary guidelines, we can help counteract misinformation and promote better health decisions. Thank you for your time.
Hi, Jodi Wachs. I'm a physician informatician, founder of Contexa LLC. This work was done with the support of Blackford Middleton, and today we are discussing the barriers to implementing and maintaining current evidence-based clinical decision support. We conducted market research of semi-structured interviews of 25 people across 17 organizations. 75% of those people were informaticians, and over half of the organizations were academic medical centers or community hospitals within an academic medical center. We looked at clinical decision support ranging from order sets, templates, alerts, to even information presentation. And we identified 4 common themes related to the life cycle of clinical decision support, which includes how clinical decision support is identified, implemented, and maintained at these organizations. These themes consisted of outdated decision support and alerts, vague clinical guidelines, administrative barriers, and the concept of political socialization, which we'll talk about more. Now, 47% of the 17 organizations acknowledge the existence of outdated decision support and alerts. This does not include order sets or order set maintenance, which does have some Joint Commission regulations associated with it. 25% of those organizations were unaware of any type of decision support review process. Another 28% were very clear that a CDS review process existed, yet 2/3 expressed that they were unable to keep up with the policies for review due to limited resources or the lack of a centralized clinical decision support ownership or responsibility for maintaining that decision support. 47% of organizations reported difficulty in implementing the evidence-based clinical decision support because recommendations are often vague and not specific enough. People describe the majority of the decision support as covering processes or administrative type issues rather than actually being related directly to evidence-based guidelines. As a result, the clinical decision support that makes it into the EHR is primarily around getting the work done or financial regulations rather than necessarily guidelines or evidence. The clinical decision support suggestions often came from safety events, regulatory, financial, quality requirements, and then, of course, sometimes providers. All organizations had some form of a committee involved in the decision-making for decision support. Often, several committees and processes, depending on the type of decision support, would be present. So, for example, there would be one type of committee if it involved medications, another type of committee if it was an alert. This added sometimes to the confusion for proposers of decision support. There's often, as well, a medical committee that identifies and improves the best clinical practices prior to considering any type of clinical decision support at the CDS committee for incorporation into the EHR. Now, over half of the organizations describe this concept of political socialization. This is a process that occurs amongst the clinical staff when the provider individually obtains alignment and buy-in amongst peers for consensus of evidence-based clinical recommendations. The provider needs to almost campaign for this recommendation to become a practice, and it's required even prior to discussion of the clinical topic at the medical committee, and is assumed that the evidence has been addressed by the time it gets to the CDS committee for incorporation into the EHR. It's an extremely time-consuming process that further delays the implementation of guidelines into clinical decision support. Most organizations acknowledged having some form of outdated decision support in their system, and this brings with it the risks of increased mortality, morbidity, and cost. In addition, half of the decision support is really not related to evidence-based medicine, but rather due to processes or administrative work and facilitating those aspects. So should we really be calling this clinical decision support? In the end, our key takeaways are that we really need to be considering the entire clinical decision support lifecycle. And we propose that a national repository of evidence-based, standard-aligned knowledge artifacts will support CDS implementers in adopting and maintaining clinical decision support more easily, while also keeping pace with the rapid changes. Thank you for your time.